Hi guys, what's up? In this video we're gonna talk about something called pneumothorax. Well, it's two words, pneumothorax. The first part is really referring to the air, while the second part is referring to the chest. Okay, so what's pneumothorax? Pneumothorax is the presence of air in the pleural space, which can either occur spontaneously or result from a heterogenic injury to the lung or chest wall. Well, now let's focus on the classification of pneumothorax. We have three corners of classification: primary spontaneous pneumothorax, secondary pneumothorax, and traumatic. So let's focus on the first one, which is primary spontaneous pneumothorax. Occurs in patients with no history of lung disease. Okay, air escapes from the lung into the pleural space through a small rupture of pleural bulb or pulmonary end of pleural adhesion. So we have smoking, tall stature, and the presence of the apical subpleural bulb are what are risk factors. And the second one, we have what? Secondary pneumothorax affects patient with what? Pre-existing lung disease, is associated with high mortality rates. I mean, underlying most commonly COPD, chronic obstructive pulmonary disease, TB, tuberculosis, pulmonary infarcts, and lung cancer. And the third one, we have traumatic pneumothorax, which is iatrogenic following thoracic surgery or chest wall injury. Okay, so these are all regarding what classification of pneumothorax. As I mentioned, we have three corners. Primary spontaneous pneumothorax affects a patient with what? With no history of lung disease. And the second one, which is secondary pneumothorax, affects patient with pre-existing lung disease, most commonly COPD and TB. Okay, and the third one, we have traumatic, which is iatrogenic following thoracic surgery or chest wall injury. Well, now let's focus on the types of the pneumothorax. We have three types: closed type, open type, and tension type. Okay, let's focus on the first one, which is closed type. The mean pleural pressure remains negative. Spontaneous reabsorption of air and re-expansion of the lung occur over a few days or weeks. Well, the second type, we have opened type. The communication fails to cell and air continue pass through the what? Between the bronchial tree and pleural space. So in this type, the mean pleural pressure is what? Atmospheric. Well, the third one, which is tension type, in this type, the mean pleural pressure is positive, okay, and mediastinal shift to opposite side, okay. The communication between the airway and pleural space acts as one-way valve, okay, allowing air to pass to the into the pleural space during inspiration, but not to escape during expiration. Well, you know what happens with pneumothorax. When you get some air into the pleural space, we lose that vacuum that's pulling the lung open, so the lung is what allows it to collapse. Okay, so in the normal state of the lung is what is collapsed, but the reasons why it stays open because of negative pressure of that vacuum that's pulling it what open from the outside. So when we lose that vacuum in the pleural space, the lung will collapse. So this is called pneumothorax. Well, and now let's focus on the clinical features of the what? Pneumothorax. The first one, the most common one, is what? Sudden onset, severe, or what we call unilateral thoracic chest pain, okay, or breathlessness. The second one, we have what? In patient with underlying lung disease, breathlessness can be severe and what may not resolve spontaneously. The third one, we have what? In those with what? Small pneumothorax, many clinical or physical examinations normal, and those with large pneumothorax, I mean what? More than 15% of hemithorax, which is called large pneumothorax, is what? Decrease or absent breath sounds. And the fourth one, which is what? The combination of absence breath sounds and resonant percussion of the chest is what? Diagnostic for pneumothorax is important. Okay, and the fifth one, well, the last one, can say tension pneumothorax. There's rapidly progressive breathlessness associated with what? Tachycardia, hypotension, cyanosis, and tracheal displacement away from the side of the what? Silent hemithorax. And now let's focus on the investigation of the pneumothorax. Okay, a patient with pneumothorax will send for chest x-ray and CT. In the chest x-ray shows that sharply defined edge of the deflated lung with what? Complete translucence between this and the chest wall. Okay, and also show the what? Extent of mediastinal displacement, and also show the what? Pleural fluid. Okay, while the CT is used in difficult cases to avoid what? Misdirected attempts at aspiration. Well, now let's focus on management of the pneumothorax. Primary pneumothorax, in which patient isn't breathlessness, normally resolves without intervention. Okay, in young patient presenting with what? Moderate or large spontaneous primary pneumothorax, percutaneous needle aspiration of air is performed. And the third one, we have intercostal drainage and inpatient observation are usually required, particularly in those over 50 years old, in those with pulmonary compromise. And the fourth one, we have what? If there is tension pneumothorax, immediate release of positive pressure by insertion of blunt cannula into the pleural space may be beneficial, allowing time to prepare for what? For chest drain insertion. And the fifth one, we have the drain should be removed in the morning after lung has fully reinflated. Also, supporting oxygen may speed resolution. In patient with those with what? With closed pneumothorax, should advise it to not to fly, okay, and advise to stop smoking. Okay guys, here we have management of tension pneumothorax as I brought you from the Davidson, okay, about the tension pneumothorax management. So here let's focus on this step by step. Okay, here the first one, we have mediastinal shift with or without hypotension in tension pneumothorax. If it's yes, okay, we'll jump to the what? To prepare or perform what? Intercostal tube drainage attached to the underwater seal device. Okay, if it's not, okay, he or she got chronic lung disease. If it's yes, okay, again we're gonna intercostal tube. Okay, if there's no, okay, we'll focus on the what? Estimate pneumothorax. If it's more than 15% of hemithorax or significant SCOP. If it's no, okay, just observe patient for 6 hours or out and then follow up. Okay, if it's yes, okay, we'll focus on the age of the patient. Okay, if it's more than or over the 50 years old, yes, okay, again we'll jump to the what? Intercostal tube drainage again. If it's not, okay, we'll jump to the what? Perform the percutaneous needle aspiration. And then if it's more than 2.5 liter air aspirated or pneumothorax persists, if it's yes, again we'll jump to the intercostal tube. If it's not, okay, just follow up and observe patient. That's all about the pneumothorax in general, clinical feature, investigation and management. Thanks for watching. Hope you get a benefit from this video.